This module will be on coding, tips to avoid denial. All of the documentation requirements and guidelines are found in the Medicare Benefit Policy Manual. Manual 102 includes more than 20 chapters, and Chapter 15 is the one that describes what is required in outpatient PT, OT, and ST documentation. The chapter, however, is named Cover Medical and Other Health Services. So when you go to find it, look for that one, and then go to Section 220 and 230 where you will find the therapy guidelines. National Government Services is the local Medicare administrative contractor for the state of Illinois. Therefore, you can find more guidance on its website. They have published a local coverage determination for outpatient PT and OT services, which all Part B providers of therapy in Illinois should be aware of. So throughout this module, there is additional guidance included from it. I did not include the web link for NGS because it is too long, but if you just Google search NGS for Illinois, you will be able to find it. The section in the Medicare manuals for treatment notes, Chapter 15, Section 230.3b, indicates the amount of time for each specific intervention modality provided to the patient is not required to be documented in the treatment note. However, the total number of timed minutes must be documented. The total minutes of active treatment counted for all 15-minute timed codes includes all direct treatment time. It should not include documentation time after treatment or extended rest periods and other stopping points. In other words, it must be the time spent providing the actual service. However, total treatment minutes must also be documented. So this includes time spent providing services represented by untimed codes. So in this example provided, how much time was spent in evaluation? We don't know because there is not time specified for all the untimed procedure codes. We might assume that 60 minus 24 equals the amount of time spent in the evaluation, but that is not clear because in this example, are we to assume here that the evaluation only lasted for 10 minutes? That's why it's important that you document on the day of evaluation how much time was spent in the evaluation, because the amount of untimed codes might be other things included as well. For instance, electrical stimulation or other procedural modalities. CMS also expects that the patient contact time for each unit will average 15 minutes, which means that they do not expect to see routine billing of minutes that are just enough to get to the next unit of care. That could be repetitive billing of 25 minutes, because 23 takes you to 2 units, or repetitive billing of 38 minutes, because 38 rather than 37 gets you 3 units, or routine billing of 54 minutes, because that's just enough to get you to 4 units. There were several Rock Valley charts where there was evidence that every single visit billed was either 38 or 40 minutes. This kind of activity might be seen as a trend or pattern that would invite additional scrutiny of whether the patient's treatment was individualized or whether there was an effort to provide limited treatment while making the most revenue. Another trend in several charts was when billing changed from 35 minutes to 45 minutes or 40 minutes to 55 minutes, yet the documentation of exercises did not change at all. When this occurs, there could be a very good reason, but the reason why one visit took longer to go through those exercises than the day prior or the visit prior, there should be documentation to explain why. So let's look at this example. You have gait training and you have new step on this day, 2/28. Now, what was billed on this day was therapeutic exercise and therapeutic activities. That could raise question in a review. Why? Because there's no therapeutic activities listed here, but there is gait training. Yet gait training was not billed. So was the gait training less than 5 minutes? Would it be hard to believe that 2 laps of gait training could be done in less than 5 minutes? Perhaps, but that in addition to the gait training and the parallel bars. Yet, on the other hand, there were no other therapeutic activities documented. So it's very important to be sure that your documentation matches up with the codes that you're choosing. Here's another example. On this date, we have this listing of things that were done. Therapeutic exercise for 25 minutes, nothing in neuro, nothing in therapeutic activity, 15 in manual therapy. Yet the bill on this day billed 1 unit of therapeutic exercise and 1 unit of therapeutic activities. But on the note for that bill, there was no minutes documented in therapeutic activities. So this bill should have had 2 units of TheraX instead of 1 and 1. In this example, this patient's treatment on April the 5th showed 7 different activities. 1 unit of therapeutic exercise was billed, and 1 unit of therapeutic activities was billed. On this patient, the same patient on April the 10th only had 4 activities versus 7 on the day before, but the units billed were the same. 1 unit of TheraX and 1 unit of therapeutic activities. The documentation didn't explain why there was still the amount of same time billed between the 2 days, yet the only thing that was different between one day and the next was that you provided less things. So was more time spent on each of these things? Was there more instruction given? Was the patient having more difficulty? Those are the kinds of things that need to be documented in the comments section or somewhere else in the note. There's also would be helpful to have more information about which things were billed as therapeutic activities and which things were billed as therapeutic exercise. As we'll see in just a minute, therapeutic exercise is defined as any activity that is for the purposes of strengthening or increasing range of motion. So we have several things here that are listed as either strengthening or range of motion, and yet we have a unit of therapeutic activities. So it's something to keep in mind. This example provides an illustration of another example of why you need to differentiate between what is TheraX and what is therapeutic activities. It is very difficult to know based on the charting in the documentation. Just because the intervention has the name dynamic stability doesn't automatically make it therapeutic activities. Marching can be a strengthening exercise or a gait training exercise. There needs to be more explanation, such as context, the amount of cueing given, what the goal of the activity is. So differentiating between therapeutic exercise and therapeutic activities and trying to provide more context there is important. So as I mentioned, let's review the definitions of some of these CPT codes. These definitions come from the American Medical Association, who owns the CPT codes. Therefore, whenever they are billed, their definitions must be followed. You are telling Medicare, when you bill TheraX, I did strength and endurance, range of motion, or flexibility activities. So it's performed with a patient, either actively, active assisted, or passively. It is considered reasonable and necessary if the patient has one of the following conditions present. They have a weakness, contracture, stiffness, coordination deficits, abnormal posture, or a muscle imbalance. The patient may need to improve mobility, stretch, strengthening, coordination, control, dexterity, range of motion, or endurance. The documentation for therapeutic exercise must show objective loss of joint motion, strength, or mobility. For instance, degrees of motion, strength grades, levels of assistance. Prolonged passive range of motion is not considered a skilled service, and will be reviewed for medical necessity. The documentation should reflect changes to the exercise program. That is one way of demonstrating how the skills of a therapist are required to carry out the service. So examples might be, as we showed in the last module, in changing the surface on which the exercises are performed, increasing intensity, increasing progressive resistance, documenting whether the exercises are closed chain or open chain, whether they're done with eyes open or eyes closed. So there's a lot of different ways that you can show progression of exercise programs. One of the best ways is to show that you are moving away and introducing new exercises of varying progressive levels. So not doing the same exercises over and over again. In other words, adding new ones and dropping off the old ones along the way. Gait training might be reasonable and necessary for patients whose walking abilities have been impaired by neurological, muscular, or skeletal abnormalities or trauma. Specific indications for gait include the patient may have a chronic, progressively debilitating condition. The patient may have had an injury or condition that requires instruction in the use of a device. They may have been fitted with a brace or lower limb prosthesis. They may be experiencing falls due to poor gait sequencing or poor technique. It is not considered reasonable and necessary when the patient's walking ability is not expected to improve. Also, repetitive walk strengthening exercises to just increase endurance do not require the skills of a therapist and won't be reasonable and necessary. That's why when you're documenting for gait training, it's very important to talk about balance and gait patterns and what you're doing to try to change those gait patterns. How much assistance you're giving, whether it's cognitive or physical. How that assistance is improving. In other words, it's decreasing over time. Perhaps how the patient's safety is improving, their posture is improving. And again, trying to measure these with as many objective measures as possible. That's why standardized tests are good. The Berg Balance Test, the Dynamic Gait Index. These things are important to ensure that you can support the medical necessity of repetitive gait training. Manual therapy techniques are defined as mobilizations, manipulations, manual lymphatic drainage, and manual traction. It may be used if restricted joint motion is present and documented. It can be used as an adjunct to therapeutic exercise when you have loss of articular motion and flexibility. You might build this code to reduce lymphedema by routing the fluid to functional pathways and preventing backflow as those new routes become established. This kind of therapy involves intensive treatment to reduce the size of an extremity using both manual decongestive therapy and serial compression bandaging. It's important in documentation to talk about how the joint mobs are an adjunct to therapeutic exercise. The range of motion is not part of the joint mobs, it's separate from therapeutic exercise. But you are using both of those together, adjunctively. When you're doing soft tissue mobilization, it's always good, rather than just to use STM, to talk specifically about the type of soft tissue mobilization. Again, that reinforces the skill level. You want to describe your joints in feel, before and after joint mobs. You could do that at the beginning of the treatment and then at the end of the treatment. You can talk about how a patient's range of motion may have increased after joint mobs. And always documenting those subjective and objective measures of how the patient responds to it. That's always a good thing. Now, this was seen quite frequently in Rock Valley charts. This kind of thing would be an automatic denial of manual therapy in the event of an audit. I know many therapists indicate they are doing this kind of passive range of motion to stretch the joint capsule or to maintain gains. But again, if you're joint stretching after joint mobilization, then rather than saying it's passive range of motion, talk about it being joint stretching. Talk about how you're trying to maintain the gains and the elasticity in the capsule that you've achieved through the joint mobs. That's a much different skill set and clinical analysis that's required to document that sort of thing rather than just saying passive range of motion. Therapeutic activities are procedures that involve the use of functional activities, bending, lifting, carrying, reaching, catching, transfers, to improve functional performance in a progressive manner. Now, it's usually directed at a loss of mobility, strength, balance, or coordination, designed to address a specific functional need, directed at a specific outcome. What's missing in some of the Rock Valley charts is that correlation between the type of exercise performed and what specific body part or body motion or body movement or goal that this is designed to address. If they're going to be repeated visit over visit, then you need to conclude how much cues you're giving. You need to show how those are decreasing over time, perhaps how the patient's balance is improving over time, so that, again, it doesn't look repetitive, but it shows that the patient is able to retain the information mentally, but also his muscle memory is retaining it, and they're becoming more independent with that motion, and then show how it's carried over into functional activities. And then you would be able to move on to the next activity and not keep repeating the same thing. Frequently, modalities were used from visit 1 all the way through discharge in the Rock Valley charts. Medicare expects that the use of passive modalities will decline through the episode of care. It's expected that they are used initially to reduce pain, joint swelling, increase joint movement, but then they would be replaced with active movements once those initial acute symptoms are resolved. If they don't resolve, then the clinician should be thinking about what else to do, since if the acute symptoms aren't resolving, it would indicate that the agent or the modality is not working. Remember these terms I've reviewed in Module 3. Understand what the definition of skilled is all throughout the episode, what reasonable is. In other words, is it reasonable to continue to use modalities or interventions that you used on visit 1? Is it reasonable to think the patient would still need to do those with you on visit 12? And then necessary. When a patient is nearing discharge, is it necessary to continue to use the modality or to continue to do the soft tissue mobilization? If there are still restrictions and pain and that sort of thing, then of course it is. But be sure and think about what is necessary as a patient is tapering towards discharge. And that concludes this module on coding.